Let's begin. Hemodynamic monitoring in the AR, and I've given it a heading, a full circle, because we use invasive monitoring, we use minimally invasive, we use non-invasive, and the entire circle of life keeps coming on and on to us, and we get confused as to which one to actually use for a particular patient in the ER or even in the ICU. So I like beginning with quotes or cartoons, and here, when does life begin? So one is at the time of conception, one is at birth, and then when you get your driver's license or you are 18 or 21 plus, when you can do probably what you want. Similarly, what are the questions I want answered in my hemodynamic monitoring? And these would be, is my patient fluid responsive? Not only just the fluid status, but is my patient fluid responsive? What is the cardiac output and the contractility of the heart? How is it behaving? And what is the tissue perfusion and the organ failure? Or we have to try to prevent that. We make a lot of presumptions when we actually do hemodynamic monitoring. And that is, we presume that pressure is equal to flow. And by measuring pressure, we presume that we are measuring flow. And by measuring both, we presume that it is equal to perfusion. We also presume that perfusion is equal to tissue uptake, and then the technique or the monitoring device which I use, I am the best at it and I am familiar with it, but there's so much more that we need to understand. And then finally, now in the last 10 years, we have realized that POCUS is probably the BAP of all hemodynamics, but there are some caveats there, and these presumptions keep going on. But despite that, I'm going to give you in the next 30 minutes or so how we can understand hemodynamic monitoring. So the choice of my technology will depend upon a few questions that I might want to ask. One is my monitoring tool a static tool or a dynamic tool? Is it an upstream or a downstream tool or marker? What is the fluid status of my patient? Is the patient fluid responsive? And if responsive, how much can I give? What is the cardiac output, perfusion markers? What is the microcirculation at this level? And why actually am I doing this monitoring? And do I have a monitor that might predict hemodynamic instability in the next few minutes or so? Probably yes. And towards the end, I might show you that. And can, in this era, the AI be integrated into my hemodynamic tool? So there are so many questions, and I'll try to address most of them in the next 30 minutes. I'll confuse you all first and then make it very simple. So just a word on fluid responsiveness. Fluid responsiveness is different from fluid status. Fluid status is nothing but a static parameter. For example, CVP is 9. That's all we know. Or CVP is 6. So we probably want to fill this patient up. But fluid responsiveness is a dynamic parameter in which there is a heart-lung interaction happening. Here we give 4 ml per kg or 200 ml bolus of fluids over 5 to 10 minutes. And practically what we look at in the ER is improvement in the heart rate, blood pressure, maybe also a CVP that might improve here. But in reality and in making it an advanced tool, we need to see by giving a fluid bolus whether the improvement is extrapolated to the stroke volume, to the cardiac output, to the stroke volume variation, to the end expiratory occlusion test, or even on an echo. The caveat here is that not all fluid responsive patients need fluids. Now, for example, if we have had a lot of fluids and we have later peed a lot, and now for about 10 to 12 hours, we've not had any fluid intake. And if we are in a hot season, and if we do our IVCs and the echo, we might have collapsible IVCs, and we might be responsive to the fluid challenge. But do we really need that fluid challenge is the question. So there are so many permutations and combinations we need to keep in mind. There is always a fight between giving the fluids and resuscitating the patient. So as ER physicians, we always talk about resuscitation all the way through. But then comes a time when we may have overloaded and we might want to now de-resuscitate these patients. So there is again more confusion on this issue. So, as I said, the quote that I love here is not everything that counts can be counted, and not everything that can be counted counts. And therefore, a number like a CVP or a BP or a cardiac output does not only matter, but it is looking at the patient as a whole. And Albert Einstein always I like quoting because he was extremely intelligent in making these quotes. So first we understand a little about the hemodynamics before we move on to actually the tools. So we know that preload, contractility, and afterload, all three are responsible for the stroke volume. Stroke volume into heart rate is cardiac output, and cardiac output into systemic vascular resistance is blood pressure. So we are only looking usually at the blood pressure low, blood pressure high, blood pressure normal. We give vasopressors or we give ionotropes depending upon what is low. But when you are looking at blood pressure, remember, there are so many factors which cause this BP, and that is the systemic vascular, the preload, the contractility, and so on and so forth. So, for example, if we divide our shocks into hypovolemic, cardiogenic, and distributive, hypovolemic is and we also know that blood pressure is cardiac output into SVR. So, if the cardiac output is low, the SVR will be high, and SVR is low, cardiac output will be high. So, for example, in a preload shock, patient is hypovolemic, dehydrated from gastroenteritis, or trauma patients who have bled a lot would be hypovolemic. Because of that, the cardiac output will be low, and because of that, the SVR will be actually high. So the arrow was shown wrong. Here, the preload is low, leading to less filling of the heart, and cardiac output is low. And then as a compensation, the SVR is high. In cardiogenic, the problem is cardiac output is low, as shown in the red. Because of that, there is back pressure, and there would be a high preload, and there would be an increase in the afterload in these cases. And these two shocks are also known as the cold clammy or the cold shocks. Distributive shock is where there is basically a problem with the tissue level, and this is pathognomic of septic or any other kind of anaphylactic shock, and even neurogenic shock. So here what happens is the SVR is low. As a compensation, the cardiac output is high here, and the preload would be relatively low. So here, if I ask you a question, what is the shock, or which is the shock in which you have a high cardiac output, then the answer would be distributive shock. Let us dive deep down into the tissue level and understand the oxygen. What does the blood and the oxygen together do in the body and into the tissues and the organs? So we have a delivery of oxygen, which is nothing but hemoglobin, cardiac output, and the hemoglobin saturation of oxygen. These three, so oxygen, the hemoglobin, and the cardiac output will decide your delivery of oxygen, which is 1 liter out of 5 liters of blood in the body. So every 5 liters carries 1 liter of oxygen in our body. But the tissues are not very greedy, and they only need 25% of that, which is the oxygen extraction ratio. This leads to a VO2, which is the oxygen uptake of only 250 ml. And then what goes into the venous side is 75%, which is 750 ml. And therefore, you can understand that the arterial saturation is always about 100%, and the venous saturation should be 75%. This is actually the tissue level here, which is the VO2. Now, just by looking at the SCVO2 or the SVO2, let me just tell you, this will be high in patients who have DO2, which is high, and the extraction, which is low. Or this would be low if the delivery or cardiac output is low and the extraction is high. So this is kind of an understanding. Sorry if I've confused you all, but for restraint of time, I need to go a little quick on this. But if we understand how the oxygen is delivered to the tissue level, we would probably understand the hemodynamic monitoring tools. Now, the first section of the monitoring is the invasive technology. And as Fossman actually in 1929 put a plastic tube in the heart and punctured his own arm vein. Then came the arterial line in 49, in 69 the CVP, and in 1970 the Swan-Ganz, two different scientists, but it is also known as the PA catheter. So arterial blood pressure is very, very important, and arterial lines are important for us in the ER to monitor these patients who are hemodynamically unstable. And when we look at the map, it is an easy formula is 1/3 systolic plus 2/3 diastolic. And this is the way I remember it rather than upon 3. That is because we have diagnosed, we have found out this formula of map because the systole is always 1/3 the cardiac cycle and the diastole is always 2/3 the cardiac cycle. And that is why the area under the curve of the arterial line or the trace would be the MAP, which is a number given on the screen. Now the waveforms as per the side, the further you go away, the systole will be higher and higher. So you can see the femoral and the dorsalis pedis, where the further you go away, the peak will be high of the systole, but it will get narrower. And finally, your mean arterial pressure might remain the same. We should also, whenever we look at the arterial line, we should know the flush test and know whether the trace that we are getting is appropriate or not. So you should get a proper flush, and then you should have 2 reverberations, which would be normal. So you would have 2 oscillations here, and that would be a normal test. But if you have an inadequate flush, it becomes underdamped. It is not a straight line. And then you would have not more than 2 reverberations, and that becomes many reverberations, and that is underdamped. Whereas an overdamped trace is a trace in which you will have almost 0 reverberations, and that would be an overdamped trace. So we need to keep doing the flush test whenever we use an arterial line in order to understand that our tracings are appropriate or not. And this arterial line is not only now utilized for measuring the blood pressure, but it also can be used for a load of other tests, which I will come to in a bit, called as the dynamic parameters. This is just one slide which tells you everything that you might want to know about the arterial. It's not ABG, it's arterial line. And in this arterial line, sorry for that, the arterial line, basically, what is the indication, what are the hazards, how the tracing looks, what the dicrotic notch means that the aortic valve has closed and the diastole now begins, and the way of actually finding the phlebostatic axis. So this is pretty easy in understanding how an arterial line is done, and most of our unstable patients should always get that. Then comes the CVP, and the central venous pressure is basically, again, based on assumptions. We presume that the CVP that we look at is equal to the right atrial pressure, which is in turn equal to the right ventricular end diastolic pressure, which in turn is equal to the right ventricular end diastolic volume. And therefore, we presume that what CVP we are looking at is equal to the preload or the venous return, which is not really so. And therefore, we need to understand the limitations of the CVP reading as well. We definitely use central lines because we need to give vasopressors and ionotropes, but as a monitoring tool, it is unfortunately a little weak. And this is exactly how we would measure. And this is the phlebostatic axis, which I was mentioning, which is the intersection of the fourth intercostal space and the mid-axillary line or the anterior axillary line. And that's where the RA would be. So your transducer should be attached there. And this is how a CVP recording can be done. Whether in the flat position or 30 or 40 degrees high position, the transducer should always be zeroed at the phlebostatic axis. So, talking about the CVP, when should we be measuring it? Always remember, intrathoracic, whatever we measure should always be end expiratory. And let me give you an example here. If our patient is self-ventilating, in self-ventilating, the inspiration is negative and the expiration is positive. And therefore, I will actually look at this line where the end expiration happens. But if the same patient now goes on a ventilator and is under positive pressure ventilation, the inspiration is now positive and the expiration is now negative. And therefore, we will be looking at the expiratory and expiratory waveform. So when a CVP number is thrown at you from the module, it may say 15/5, a mean of CVP of 10. That's not what we should be looking at. We should make sure that we convert the static CVP parameter into a dynamic parameter. and actually look at the end expiratory part on the tracing and then judge what actually is the CVP. This is much more important when we have a patient of diabetic ketoacidosis who has air hunger and there are huge swings in the CVP and you really don't know what mean or what CVP to follow. So you must always look at the tracing and see the end expiratory part. Whenever, this is my trick question, when you have a high CVP, but the patient still needs fluids, so there are only 4 or 5 conditions. So patient CVP is high, BP is low, and you want to give these patients fluids despite the CVP being high. The first is pulmonary embolism, then is cardiac tamponade, then is constrictive pericarditis, then is tension pneumothorax, and then right ventricular dysfunction or infarct. So these are the 5 usual conditions in which despite a high CVP, we must suspect them and then probably load them a little more. This is another chart of the CVP in which it tells you the sites where you should be putting it. You should also, it gives you a tracing and the indications and even the complications of the CVP, which I cannot really get into details here. But nowadays, we must always try and do a ultrasound guided or focus guided central line and arterial line insertions, because the earlier chances of, in the best of hands, with a jugular vein of a pneumothorax was 1% and subclavian was 3%. But with the advent of focus induced or guided central line insertions, it should be near 0. So this is how we have evolved in our technology. So CVP is unreliable as a monitoring tool. Very useful in all the ERs and ICUs. And if you take a consensus, 90% of the ERs and ICUs still depend upon the CVP alone. And that's a little unfortunate, though I would use it all the time, but I would definitely look at other parameters in some patients. So a CVP is basically like flipping a coin, and it is only 50% of the times very accurate. Otherwise, it may not be. Coming to the PA catheter, so I'm going to give you all the monitoring tools that I know of exist in the world, and later we will come to some algorithms. So a PA catheter basically is a balloon-tipped flotation catheter, which is 4 lumen, and it is in the pulmonary artery. It not only gives you a preload in terms of CVP and wedge, or a contractility in terms of cardiac output and cardiac index, or an afterload in terms of SVR and SVR index, but it tells you tissue perfusion, which I just showed you. It tells you about the DO2, the VO2, the extraction, and the SVO2 or the SCVO2, which is mixed venous oxygen saturation. And this is how we insert or float a PA catheter. First, it is in the RA, then it is in the RV, and then in the pulmonary artery with the balloon inflated, it will look like a systolic and diastolic. And when the, deflated, and when the balloon is inflated, it will look like a wedge, which is nothing but the left atrial pressure. It should be put in the West zone 2, which I'm not going into details. But this is how, if the catheter is in the pulmonary artery, there is no flow between that and the LA on the other side. And therefore, it not only measures the RA pressure, which is the CVP, but it also measures the pulmonary artery wedge pressure or the capillary wedge pressure, which is actually equal to the left atrial pressure. So whenever there is a right ventricular dysfunction, a PA catheter might be useful. Across the updates and literature, since the last 15 years, people have stopped using the PA catheters because they say the mortality is higher. So if you are an outdated intensivist or an emergency physician, if you are using a PA catheter, but believe me, there is still a load of indications where it can be used. And the PA catheter actually taught us not only, the hemodynamics, but even the tissue parameters of hemodynamics. Coming to the non-invasive, we have electrical impedance cardiography. We then had the esophageal Dopplers. Both are given up now. Then we have the echo. We have the NICO, the PLR, the clear sight, and I will just take you through each one in brief. So, as I mentioned, there is impedance cardiography and esophageal Dopplers not used now. because of it being very cumbersome and not giving appropriate readings. But the echo, transthoracic echo or the POCUS is very good. It not only tells you the ejection fraction, you can do a quick look or an eyeballing, or you can do a Simpson's formula, or you could look at the IVC variability, or you could look at a lung ultrasound and get all your A lines, B lines, so much and so forth. Then we have a passive leg raising test. We have an end expiratory esophageal test. We have a tidal volume challenge test, and both these and all these are usually done on a ventilated patient. And then you have a clear site, which is again a non-invasive technology. So as you can see, there are these 5 views in which we would do a transthoracic echo. And here in the lung echo, as you can see the comet or the B lines. You can see multiple B lines, more the B lines, more the interstitial pattern or the pulmonary edema. And here you can see the IVC is plethoric and it is hardly collapsing. And this is the RA, and you should always measure it near the hepatic vein. So this would also indicate the amount of fluid status of the patient. And then you can quickly look at the echo findings, and you might even see how good or bad the ejection fraction is. You can just do an eyeballing, or you might even do a proper Simpson's in the apical 4-chamber view. There is an algorithm if you are following an ultrasound. Patient is underfilled less than 1.5 with the IVC or distended. Is it intubated or non-intubated? You might give fluid resuscitation with crystalloids, or you might do a fluid test if there are A lines. But if there are B lines, you would restrict the fluid, hold the crystalloids, and start your vasoactive agents much earlier for hypotension. So there is a method in which you need to use your tool appropriately. And the limitations of this echo. So I don't agree that it is the BAP of all measurements, but yes, it is a very useful tool. And here it has limitations in terms of it does not account for the intrathoracic pressure. It does not account for the increase in the right atrial pressure, and it does not account for the interference of the IVC compliance, depending upon many other factors. So despite a very useful tool, we must always correlate it with clinical and other parameters like the mental status, the urine output, the skin perfusion, and not look at it just as one end all and be all of all parameters. If you are smart enough in using the POCUS well, you might even look at the VTI, which is the velocity time integral. And this velocity time integral is nothing but a product or multiplication of LVOT and the velocity time index. And this usually is 17 to 18. And it's a very important factor to understand the stroke volume. And this is how you actually do it. You check the LVOT, and you also do a apical 4-chamber, and you look at the VTI, and then you multiply that with the area, and that gives you the stroke volume. And this is a good way of knowing the VTI and a good way of knowing the LVOT, which is the pi r square in the formula. And by looking at that, you can actually see fluid responsiveness, the cardiogenic problems, the distributive problems, etc. And again, you have another algorithm with looking only at the VTI, where it may be less than 16, more than 20, or 16 and 20, where the patient is intubated, ventilated, and gives you all the types of shocks here. So whichever tool you're using, please use it appropriately, and don't just look at the IVC and come out. Then comes the passive leg raising, the 5 rules. Not a drop of fluid is given, and you are using your own fluid from the legs into the circulation. And these are the 5 points where you are actually raising the leg at 45 degrees. It has to be done correctly at the hip. And then you are assessing the cardiac output and the changes in the stroke volume before and after this PLR. And it is extremely useful. Many a times we can have specific pulse variation index being seen in the specialized pulse oximeters. And here an indication of 10% or less would indicate that we can give fluids. And if it is more than 24, then less likely that they would need fluids. Then a very simple bedside test is the CRT, which is capillary refill time. And here it can be done in a right technique. And if more than 3 seconds is supposed to be abnormal. But again, each technique has its limitations. And here you can have environmental temperature, skin temperature, quality of the technique, the place of the pressure, and the light in the room causing issues with the CRT. There was a very nice study called the Andromeda study, shock study, in which they used a glass microscope slide over the ventral part of the distal phalanx of the index finger, and they used it for 10 seconds as a pressure till the skin became white, and then the refill time was seen, and if it was more than 3 seconds, it was considered to be abnormal. And this study actually compared this with a standard technique of serum lactate, which we love sending from the ER, and they found that there was no difference in terms of mortality. But in the post hoc analysis, it had, in the CRT group, actually required less fluids, less vasopressors, and had a lower risk of death. So just by looking at a simple test like this, if done appropriately, can even prevent so many more unnecessary labs and tests to be done. Then comes an end expiratory esophageal occlusion test, and this is very similar. You occlude occlude the pressure for 15 seconds in the end expiratory phase, just as you do on a ventilator to check your auto PEEP or intrinsic PEEP, and then you see the stroke volume difference. And if it is more than 5%, then this patient is fluid responsive. This is obviously done on a ventilated patient. And these are again the 5 or 6 points in which you can actually, just like the PLR, here you are doing a different test, which is the esophageal end expiratory occlusion test. Then you might also do a tidal volume challenge. These are just mentioned to you all. We don't do it in practice, but these are ways of assessing fluid responsiveness. And here, basically, we hypothesize that if the tidal volume is 6 and now we made it 8 ml per kg, a predicted body weight, and the PPV, which is the positive pressure ventilation, no, not positive pressure, which is the pulse pressure variation, may actually vary and help to unmask those who are fluid responsive. And this is a new technique. I have not yet used it, but it's available, and it is called as a clear sight technology, in which you just put it around the index or the middle finger, and this will tell you the compliance, etc. Coming to the third part, which is kind of the final part, but my lecture is still about 15 minutes more, the minimal invasive technologies. And here you have the PICO, the LEADCO, the flow track, and you have advanced HPI, which is the Acumen, which is the hypotension predicting index monitor. And I'll just talk about all of these in a bit. So the flow track is minimally invasive, and here you need an arterial line. And what all can you do with an arterial line, I will just show you here. So you will look at the stroke volume variation, which is the stroke volume max minus the stroke volume minimum upon the stroke volume mean. And this variation is exactly, to understand easily, is opposite of CVP. So if the CVP is high, the variation is low. And if the CVP is low, the stroke volume variation is higher. So in short, when the stroke volume variation is high, the stroke volume keeps varying with inspiration and expiration. That means that the patient is fluid responsive. But if the stroke volume variation is less than 10, probably meaning CVP is high, exactly opposite, and means that patient cannot be given more fluids and may need diuretics. Then comes the PICO technology, in which there is an arterial line, there is a central line, and then there is a thermodilution which is involved. And you inject through the central line, you measure at the arterial line, and so on and so forth. And this gives you the RA, RV, LA, LV, and it also tells you the blood volume in the pulmonary trunk. It also tells you the extravascular lung volume. So, wow, this is quite a good way in actually knowing whether the fluid that you are giving is getting into the lungs. And there will be a thermal volume as well. Then this was extrapolated. The PICO was taken over by a company called Edwards, and they brought in this volley view, which is a volumetric assessment. And here, looking at the graph, as you are passing by, you can see how much fluid is there in the lungs. This is an extravascular lung water index, and this basically less than 10 is okay, but anything above that is dangerous. And here you can actually see the lungs flooding up. So you can have a visual impact in which you can look at the stroke volume, you can look at the SCVO2, which I measured, you can look at the cardiac index, the SVRI, and above all of them, you can look at the extra vascular lung volume. Now coming to, is there any prediction that I can do, a crystal ball that, oh, this patient in the next 10 minutes is going to crash in front of you? This technology, excuse me, has started in the intraoperative phase. And here, these are called as the Acumen suit or the hypotension prediction index. Anything more than 85 would predict that there is going to be a hypotensive event very soon. And here you have a monitor just like that. And as you can see, if the HPI range is above 85, then there is a 90% chance in the next 5 minutes that the patient will be hypotensive. And if it is 95 to 99, there is almost 100% chance that in the next 1 or 2 minutes, the patient is going to be hypotensive. Below that, there is less probability and less chance. So this is a newer technique in which you can actually insert this and know that the hypotension can be predicted by looking at a very complex formula which the monitor will calculate. This is not in hemodynamics, but this is just taking it further for the central hemodynamics, that is the brain hemodynamics. And this is an infrared spectrometer just put as a foresight on the temples. And this not only tells you the tissue oxygenation at the cerebral oximetry, but it looks at all the other factors which would affect this STO2 in the brain. Now I would use all these technologies and like to divide them into static and dynamic parameters. Static parameter is like, for example, a CVP, which is fluid status. CVP is 5, CVP is 10, CVP is 15. But as against that, as I said, we look at the end expiratory, we give them fluids, and we look at the fluid responsiveness at the end expiration. Then we are converting it into a dynamic parameter. So dynamic is fluid responsive and static is fluid status. The second part about dynamic is there is always a heart-lung interaction which helps to determine whether the patient will be fluid responsive and what is the interaction in the intrathoracic pressures. So examples of these static and dynamic are in this very beautiful chart. CVP, PA catheter, PICO technology are all static, whereas dynamic is stroke volume variation, a 2D echo which we all follow, a PLR, a plethysmograph, an end expiratory occlusion test, and a tidal volume challenge. Can we look at the microcirculation? So this is a probe which looks into the just under the tongue, and it is called as the OPSI technology. And by looking at that, you can make a difference out what happens in the microcirculation. To the left, A is normal microcirculation, whereas in B, you can see there is microcirculatory sludge and there is almost no flow in the microcirculation. So this would actually indicate that the microcirculation is compromised in our septic patients. I would just do one more classification, and that is upstream and downstream markers. Now, what are upstream markers? Anything before the microcirculation is upstream. Anything beyond that is downstream. And therefore, upstream markers would be looking at oxygen supply, demand, hemodynamic parameters like DO2, cardiac output, preload, afterload, oxygen carrying capacity, and the saturations. But having said that, the downstream markers are the lactase that we check, the VO2s that we check, the endothelial signaling, inflammatory mediators, base access, and the PCO2 difference in the vein and the artery. So this is very classical, and you can actually see these. And this is a pictorial diagram which divides your upstream from your downstream markers, which I just mentioned. Can artificial intelligence also get incorporated into hemodynamics? And whenever we talk about this, we are towards the end of the talk. And this was my colleagues have presented this in Jan 24. And here they are looking at the USG with velocity, prediction of hypotension, as I said, HPI, alarm fatigue, early warning, shock, and some cardiac surgeries have been studied. And there is lots of future to this. I would like a technique that I just put one line, maybe an arterial and a central, and it does all this what I discussed and gives me a algorithm, which might happen in the near future, that this patient needs so much of fluids, this patient needs so much of inotropes, and this patient is going to get better or not respond. So I think we are probably looking at AI integration in everything, including hemodynamic monitoring in the ER and the ICU. Now, you might be wondering why I have put this elephant and the 5 blind men, but those who looked at different parts of the body found a different thing, and they identified it as a tree bark or something else. And therefore, use the right tool and ask the right question is what I would need to you all to understand. Because if you are using a tool like CVP and you're saying, oh, the cardiac output is low, or you're looking at the echo and you're saying the fluids are too much or whatever, that may not be an appropriate answer. And just in light vein, you see what you are made to see depends on which side of the patient you are standing, and interpretation is always a little to be taken with a spice of salt. In summary, my friends, a monitoring technique is similar to surgery. The tool is not as important as the operator skills, and you should know exactly what you are doing and what you are using it for, and the right questions should be asked. Hence, please know your tool very well. Thank you.